Hi, I'm Dr. Raj Sundar, a family physician and a community organizer. You're listening to Healthcare for Humans, the show dedicated to educating you on how to care for culturally diverse communities so you can be a better healer. This is about everything that you wish you knew to really care for the person in front of you, not just a body system. Let's learn together. One of the reasons I do this podcast is because I truly believe that we, clinicians, caregiver systems, we're always a work in progress. And some conversations make you look at your own practice in ways that are uncomfortable but necessary. And I think this is one of them. I think about my own patients. I have a patient with developmental disability who, frankly, was never supposed to make it to 20. And he has. And what I've witnessed is how some staff, good people, well-meaning people, just don't know how to interact with him. There's an uncertainty, a hesitation. And what his caregivers want more than anything is simple. They want him to be seen as a human being. That's it. Something so basic, it almost shouldn't need to be said out loud. And yet, that's where we are. I think about my own family, someone who's deaf, who was hidden away, not given the same choices as others, treated as less than by very people who loved her. It seems like a systems problem, but it happens inside communities all the time, inside families, and, worst of all, inside exam rooms. Today's guest, Dr. Sara Ryan, is a professor of social care at Manchester Metropolitan University, who has spent decades researching the lives and the deaths of people with learning disabilities. And then she lived it. Her son Connor died at age 18 in a hospital where he should have been safe. In her book, she used a phrase that stopped me cold: social murder. The idea that when a system knows the conditions that lead to early death and does nothing, that's often an intentional byproduct and choice. So in this conversation, it's actually not about the systems and structures, but it's something more actionable for all of us. Tiny acts that matter. Noticing, acknowledging, showing someone you see them, and that you're right there alongside. Here's Dr. Sara Ryan. Sara, thanks for joining us on the podcast. Before we get started, tell me a little bit about yourself and what you do.
I'm a professor of social care at Manchester Metropolitan University, and I do a lot of research around people with learning disabilities and autistic people, and have a lovely large family.
Large families are lovely, and it's great to connect with you here. So much of the work you've done is from, I'll say, motivated by your personal experience. And the books you've written and what we're talking about today is around Connor. Tell us a little bit about Connor and how that drove you to the work that you're doing.
Yeah, so Connor was born in 1994, and it just so happened that I went back to university as a mature student, and it coincided with when he was about 2. He was diagnosed with learning disabilities and eventually lots of other labels he attracted along the way. And because I was doing my undergraduate degree, I took any opportunity I could to study learning disabilities and autism. And then I went on to do a PhD at Warwick University, looking at, it was called busy behaviour, and it was about mothers taking their children with learning disabilities out in public where they would attract consternation and lots of tutting because it seemed like the children were badly behaved. And from there, I became an academic and carried on working in this area. And then Connor died aged 18 in 2013. He had a terrible experience in a hospital, NHS hospital, where he was allowed to drown in the bath, despite specialist staff coming out of your ears around him. So that was quite a devastating and incomprehensible happening, which in the UK, I don't know about the States, led to a cover-up on the behalf of the hospital he was in, a very long fight for accountability and justice, which took 5 years before the hospital was found guilty of neglecting him. And since then, I've carried on writing and researching in this area, perhaps with more of a, what would I say, more of a critical eye to it all. I don't know. Certainly feel quite fearless now.
Yeah. Thanks for sharing that. I know you've written a book, shared this so many times, but I'm sure it never gets easier and just to reflect on everything that Connor went through. Give us, now you've thought about this, as you said, critically for some time.
Can you explain the context around learning disabilities in care for people who are just learning about this, know some people, but they don't fully understand the scope of what's happening? What would you tell them?
I would say that if you have a child who's diagnosed with learning disabilities, you can feel like it's the end of the world because it's probably the first time you've come up against this context, as we call it. And in actual fact, it isn't. It really isn't at all, but it can take quite a while to recognise that. And I think that's because societal attitudes towards people with learning disabilities are overwhelmingly negative. And that negativity means that people aren't really seen as human, which allows people to be mistreated in ways that other people wouldn't necessarily be treated. And there's an acceptance of this mistreatment, which is quite extraordinary when you start to recognise it. And so the label, the learning disability is a label. It's based on, it's not a blood test. It's not, you just start to fail certain things. You fail these things that are held to be normal developmental stages. And with that failing those stages comes the label. But with that label comes a complete transformation of your life as person A, and you become person B. But of course, you still remain person A. You are the person you are. Nothing has changed other than you get this label. But with this label comes a whole host of issues that lead to people dying premature deaths. And people in England are dying 20 to 30 years before their non-disabled peers, and yet they're not ill. It's not a life-limiting condition.
Yeah, it seems like how diagnosis can overshadow your identity, and that label itself can change your trajectory of life. I think for some people, labeling helps them make sense of what's happening, of you're having trouble, and giving it a name helps understand it and put it in a container perhaps. But it's problematic as if that changes the care that you're receiving overall, and maybe some discriminatory practices as well. In this podcast, we do talk about diverse communities, and diverse can mean so many different things, but there's some intersectionality with identities. And I find that learning disabilities is stigmatized overall, but in certain communities even more. I would love to talk about that stigma. Like, how would you talk about that stigma? I think you've maybe personally seen it, or maybe the isolation that comes from it. So what is the stigma behind it? And have you seen anybody address it successfully?
Well, it's a really interesting question. Where does the stigma come from? I don't know. I'm not sure, but there's more stigmatization in particular cultures. We have very little research in people from ethnic minority communities because it's so stigmatized. It's almost impossible to find people. I'm a trustee of a charity in Manchester that supports South Asian communities. And recently a woman came up to me and she said, do you have any ideas how we could wash my brother's hair? He's 20. And it was such a random question to ask, and it was so unexpected. But she obviously had nobody else to ask because they couldn't talk about this, her brother having learning disabilities. It is a really problematic area, and I feel that in writing the book I've just written, I'd come across intersectionality in the book as a tiny section, way tinier than any other books, because other books you'd have the whole stall laid out, wouldn't you, of all these intersectional identities and that, and how they interact with each other and the sort of relationship between them. Whereas when it comes to people with learning disabilities, that learning disability label seems to obliterate any nuance or understanding of what's actually going on the label. And that's so problematic. And we're still puzzling how to do our research better in this area and not really making any headway at all.
Have you found changing the language helps? Is it the idea of disability that makes it harder to talk about? Because there is this sense of, unless we identify or accept it as a community, it's hard to support, connect, and normalize.
Yeah, I don't know. I'm not sure, because we've got quite a strong autistic community in the UK, which is making good grounds. But then there's some tendencies within that community to punch down on people with learning disabilities, because, of course, there's an overlap, and a certain number of autistic people will have learning disabilities. Connor was diagnosed with autism. This was another thing I've written about, is that you have disability studies, massive body of evidence, research, discovery, theorising, all sorts is going on. But within that disability studies community, people with learning disabilities are marginalised from that. And so you're still like, for some reason, people, whatever their background identities, will turn around, look at the person with learning disabilities and say, no, there's no overlay, you're nothing to do with me, or I don't want anything to do with you. And it doesn't make any sense at all. There's absurdities in this area, and there's irrational statements, and there's accepting things like, well, in the UK, we can have reports published that will outline a whole set of human rights abuses of people with learning disabilities in institutional hospitals, for example, and barely makes the news. And we've got human rights lawyers, we've got charities, we've got all sorts of organisations, but everybody just seems to read it and just absorb it without comment. And I honestly don't understand how that could happen. And interestingly, a few years ago in the UK, a woman was filmed putting a cat in a wheelie bin. I don't even know why she did it, a big rubbish bin. Walking down the street, picked up a cat, put it in the bin, lid on, and the whole country went into a meltdown. It was just on the news, everybody was talking about it, and yet you could have somebody in a long-stay hospital being fed behind a perspex window, literally locked in a cell all day, 10 stone overweight because they get no exercise, and nobody does anything.
What's this idea of social murder that you brought up? What's that ideology, and how is that connected to this?
It was funny because I was commissioned to write a book about health inequalities and people with learning disabilities. And when I started reading, I thought people with learning disabilities are subject to harms on a daily basis that is just documented. And everybody's writing about it. There's inquiries, there's reports, there's research. And yet nothing is done about it. And so that sort of drew me back to Engels, who wrote the History of the Working Class, I can't remember the title, History of the Working Class People, or something like that. Yeah. And he wrote that social murder happens when the state knows the conditions that leads to premature death and they do nothing to change it. And I couldn't help, I didn't want to, but the more I read and the more I wrote, the more I could see evidence of so many breaches that were going to lead to impoverished lives and shortened lives. And the lack of government response to any of this made me think this is an example of social murder. And it happens in healthcare, it happens in social care, it happens across people's lifetimes, really.
Let's dig into the healthcare aspect of it. In what ways did you feel like that idea of social murder was captured in healthcare experiences?
I can give one example from an inquest a couple of weeks ago where a young man was taken to hospital by his parents who said he was very ill. They went to the emergency department and the first doctor saw him and tried to take blood and he wasn't very compliant with the blood taking. So he said, I can't do this, bring him back tomorrow. So the next day they took him back to the emergency department. Very unusual to do that. Anyway, they took him back and the second doctor had the same thing and said, I can't do this. You'll have to take the blood test in the community. So he was sent home and a few days later he was supposed to go and have the blood test in the community. But he was too unwell to get out of bed. So a third doctor, a general practitioner, went to see him in bed and didn't take the blood test and he died 12 hours later. Now at his inquest, all three healthcare professionals gave evidence and said he didn't look very ill. Each of the three of them said, but he didn't look very ill. And then the expert witness, who was also a medic, popped up and said he was obviously really ill because he died 12 hours later. And so I thought that was a really not good example because it's a terrible happening. But this, I think with healthcare professionals and people with learning disabilities, you do have this diagnostic overshadowing where you don't see beyond the learning disability. You park your medical expertise, you park that carefulness and attentiveness that you deliver to most patients. And for some reason, your practice falls short. And we hear it, there's so many cases over and over again in England where people are dying of constipation, of scabies, of all sorts of things that are eradicated for other people.
Yeah, I'm reflecting on my own experience. I told you I was a clinician, and two instances. One is this idea of different communities so stigmatized they don't even bring it up, even though you're witnessing it, and they don't want to talk about it. They just say, oh, he's just always like this. And I was like what? And they don't want to talk about it. The second piece of what you're talking about, I think it's this sense of, I have a patient that I have a long-term relationship with, and when others see him, I think they're maybe fearful. Are not fearful or uncertain on how to interact. Yeah. I think about I think you noted this of that Connor had a personality and quirks, but that got lumped into maybe it's just the learning disability. So there was not a sense of there's still a way to know this person in front of me. And that attempt to get to know them is stopped because, there's no chance when there is somebody behind there. So I think of that in healthcare too. I don't know if that captures it, because I think you had I think linking what you were saying is this idea of being difficult. And maybe you could talk about that of, this patient's difficult. So I think that changes your perspective too a little bit.
Yeah, I think that's right. And I think that was very clear in that example of not taking the blood test, because of course, you're looking at this retrospectively that the young man died. And so there's an incredulity there about why didn't you sedate him and take the blood? Why was this test done that possibly would have shown up the infection he died from? And there obviously was a fearfulness around this sense, and I do cover this in the book, this idea that people are somehow monstrous and that monstrousness is somehow threatening. And yet it's so far from what is actually the situation. And I remember in that inquest, his mother was giving evidence saying he sat in a chair really quietly for 5 hours in the emergency department. He sat there all that time really patiently, but it was the fearfulness of the doctor who didn't understand this person who seemed to be somehow other, and so couldn't use their skills and their experience to do the job they're supposed to do. And that is a real problem. And it's funny because in the book, I started to develop an idea of a collective, because I'm thinking there's a collective of people who have healthcare professionals, social care workers, support workers, sometimes family carers. All these people are part of this loose group that contribute to the impoverishment of people's lives. And then you think, what are those people in that group doing? And a lot of them are very well-meaning. They want to do a good job. They want to do the best healthcare they can or the best social care. But for some reason, when it comes to this group of patients, they're not able to. And so it's about trying to reduce the number of people in that group, basically. How do we upskill professionals to not see a person with learning disabilities as somehow monstrous and engage with them?
Yeah, it's a link to so much of, sometimes I do these episodes and a self-reflection of my practice and how I can be better or grow. And hoping listeners also sense that, and hopefully they're growing too. I think the other piece of is connected to this quote unquote difficulty in taking care of people living with learning disabilities is the good enough standard. Like what we did was good enough in this situation. And then everybody does good enough, which is substandard care. Can you share a little bit about that as well?
Yeah, I think that's absolutely right, isn't it? And I think, is it good enough because I think about it boils down to what do you know? How do you know what you know? What should you know? What do you know but you refuse to not know? You almost unknow what you know. This stuff is so straightforward. This is a group of people who need healthcare, who don't follow the rules that everybody else sticks to. That we have the most funniest memories of Connor, who used to call, it's just like a rule breaker. He would literally ask why all the time, to the extent you'd have to say, I don't know why. This is how we do it. And he would always ask why. And he'd just be very outspoken and very direct and very curious about things. And so he didn't follow all the rules, which makes him somehow a bit unclear, that people are a bit worried, what's he going to do, all this sort of thing. And so I think the good enough is a really nice way of thinking about it, because that brings back the good intent that you want to do a good job, but you're falling short because, again, it's almost like your magnets reflecting each other, isn't it? Yeah. For some reason, you won't go there 100%. Why not? Because you're fearful.
Yeah. Maybe fear is at the root of that. I'm thinking of there's another reason maybe some people say, I did my best and good enough, is that it's hard to communicate with people living with learning disabilities. So if I just can't communicate. So it's hard to take the next step. What would you say to that, and both the idea of that and maybe what you've seen done better in those situations?
That's, again, this inquest was the same. The mother was there. The mother was saying, I know him. He's really not well. Really, as a doctor, you should have this narrative humility, shouldn't you, that you apply to all your interactions as a doctor, whoever the patient is. It's very easy to give healthcare to people who are very like you, who talk in the same way, look the same way, and obviously share a lot of the same experiences. That's easy peasy, isn't it? But when you get somebody who doesn't necessarily talk, you're left like bereft of what can I do? But instead of being bereft, you should think, okay, how should we deal with this? try and communicate somehow. Ask the person who's come with the person who isn't communicating, what's the best way? How do we do this? We really want to make you feel better. So let me just find out the things I need to know in order to make you feel better. You don't just say, go home and come back tomorrow.
Have you noticed anything in the research that's effective in teaching clinicians the different aspects of caring for people with living and learning disabilities? I'm thinking of recognizing suffering. We have to do this for all patients, so it seems a little odd to say for learning disabilities, how do you recognize suffering? But this idea of there's a skill gap, it seems like, with healthcare professionals. I don't know if research has identified any ways that we could improve clinicians as a field.
First thing I'd say about that is one of the things I found writing the book is research is very much part of the problem. And we will do some research and we'll come up with a set of recommendations, say for healthcare professionals. Here we are. If you follow these recommendations, everything will be fine. And then 10 years later, somebody else pretty much does the same project, finds the same recommendations and just writes about them. So there's that aspect. I think the second part I would say to that is in the UK, we're fixated on training. We always recommend training, more training. Health practitioners need more training. And I don't think that's the case because I think there needs to be more training in the medical curriculum so that people interact with people with learning disabilities when they're training to be doctors. Because once you start interacting with people, you realise this is just a human being and I need to talk differently or I need to understand differently. So I think mingling with people and mixing from early on, if you're going to become a healthcare professional, is go and volunteer at your local day, whatever it is, club where people with learning disabilities hang out or other marginalised groups. Go and mix as much as you can because all that mixing will make your healthcare practice so much better. I think that's what I would say. And I think training can be a bit like you're training somebody to listen, pay attention, be kind, be thoughtful. Well, you don't need that training. You've got it. For some reason, you're just not applying it in that context. And in terms of trying to understand the pain, again, back to the young man's case, his mum was his pain measure. She was saying he's in pain. It's if you don't think you can communicate with the person, and I'm not saying go straight to the family carer, go straight to the support worker, because that is really problematic. You need to engage with the patient as a patient, but you do need to use different ways of communicating, and everybody communicates, really.
Yeah. Do you find that because people living with learning disabilities have suffered through so many negative experiences, they carry this trauma? So what does trauma-informed care look like for patients? Because there's, over time, probably increased mistrust, skepticism of healthcare overall as these negative experiences accumulate. So I'm thinking of being in front of a patient who comes to me after decades, maybe, of this kind of experience. I wondered what trauma-informed care looks like.
Yeah, that's interesting, because another book I wrote that was called Pockets of Brilliance, Love and Learning Disabilities. I was writing the book and it was so depressing, and I was finding it was like a real trudge because it was also negative. So I went on Twitter when Twitter was a much better place and said, has anyone got any pockets of brilliance in relation to practice, that good practice that you've come across? And people, it was so funny because it was just like this flood of stuff that people were saying things like, mostly family carers, 10 years ago, a doctor did this. And I was just like, wow, that stayed with you for 10 years. And yet what they did was so tiny. And it was things like when the doctor said to my son, oh, I love this, or, oh, you've got a great smile, or just recognises them as a person and just talks to them. It was somebody said their son was going in for an operation and they were really worried about it. When they turned up at the hospital, they had their own room and on the door was a rocket because they'd found out that he loved rockets. So put a label on with a rocket on that sort of like thoughtfulness. And somebody else, it was quite funny. There was, again, these are longer term relationships with health professionals. It's quite different if it's an emergency. But the GP surgery, they found out that the young man liked pug dogs. So when they wrote letters about appointments, they always stuck in a picture of a pug dog. So it's tiny little tiny bits of thoughtfulness. But the impact on the family, which is what these things were all so tiny. And yet for the families, they're like, my son counts. My daughter matters. This health professional, this social worker has taken the time to understand what is important to them. And they are trying to make this interaction as good as it can be, rather than as good as it gets, or how about, I can't remember how you phrased it, as good enough.
Good enough.
As good as it gets rather than good enough. And I think that's the standard, because that's what you do for most patients. You might have to go the extra mile. It might take a bit more time. You might have to allow more time for the appointment. You might have to have the light off. You might have to do all these small things to make that person feel comfortable and unthreatened. But those things are not hardly the end of the world to do that, is it?
Yeah, it's remarkable how some of the smallest moments resonate with patients, as you said, for decades sometimes. And you hear, oh, they must have done a miracle, like saved somebody's life. They sat down and said hi to me like a real person.
It's so true. The woman was talking about a decade ago was when her child entered a new GP surgery, and the GP, I think it was the GP or a nurse, said, I know nothing about your son's condition, but I'm going to find out.
Yeah.
Just to own up that you just don't know. I don't know this, but we're in this together.
Yeah.
So bear with me while I learn. Why would you not say that?
Yeah. How do our healthcare systems themselves contribute to this? We've focused on individual people a lot, but how has our systems not aligning to deliver the care that you imagine?
I think I wrote in the book that because people aren't seen as human, when something happens, it doesn't matter. So there's all these protections that should be in place in these systems. There should be protections. There should be investigatory processes that kick in if somebody dies unexpectedly. There should be all sorts of things that are embedded in the system that are just switched off when it comes to people learning disabilities. So you can have this incredible surveillance in your life that means you have to keep your bedroom door open in your supported living. You can't have a girlfriend or a boyfriend. But the minute you die unexpectedly, all of a sudden that surveillance is switched off and you're like just died of natural causes. When Connor died, the hospital trust literally said he was 18. They reported in their public board minutes he died of natural causes before they'd even had a post-mortem. So the systems fail people. But I do think, and it's funny, we were talking about this recently about, can you change systems? It's really difficult to change systems. Should you go for the individuals within those systems who do have agency to say this is wrong, that's wrong, this should never have happened? So the system question to me is a bit tricky, because you would think we had legal human rights frameworks, you would think we had all sorts of protections, but they just don't work.
Yeah, it's a hard conversation with so many communities that I feel like I'm in tension with on. The systems need change, and the only things we can control are individuals within the system. There's some gray area where individuals do design systems, right? There is a person maybe making rules for a clinic or making decisions on X, and maybe there's some influence there. But the idea of systems change is so complicated with so many weaving and interconnected variables. It's hard. But I do think it's helpful to focus on that, because sometimes I look at it from the healthcare professional standpoint, not to absolve them of the responsibility, but this idea of feeling so burnt out and feeling like there's not enough time to do what I want, and I'm doing the best that I can. We're playing with that language a little bit, understanding that systems needs to change and making sure people are advocating for it. What have you seen as successful advocacy in this space from healthcare professionals or others, and refusing to participate? We'll use that terminology again, social murder.
Oh, that's a really good question. I've used Irving Goffman's, which comes from the book Stigma, his concept of the own and the wise. The own people have the same characteristics, so that would be people with learning disabilities. And the wise are people who have an in-depth understanding of, say, people with learning disabilities. And that can come from being a family member or a professional or someone else. And it's really interesting that the wise are allies to people with learning disabilities, and the wise are the people in the healthcare settings who are doing stuff to try to make sure that people get the right healthcare. You can see who these wise people are because they speak out. They develop tools, for example. They try to make their hospital more receptive to people with learning disabilities. They champion different initiatives that are supposed to make a difference to people with learning disabilities, some of which do, some of which don't. I'm just thinking if there's a medic who happens to have a child who's autistic, And I think that helps in your allyship. So you have these people who are working to change their own hospital environment, and then they can expand that wider. So there are lots of good examples of that, but it's piecemeal. It's somebody here, it's somebody there. There's not a joining up with enough weight to make these things stick.
Yeah, building collective power. We need a lot more of that these days, it seems at least. Is there anything else that we missed as key points in the book that's worth sharing in this context for healthcare professionals?
For healthcare professionals, I think it's important to remember it's the small stuff. I think I'm a bit of a crocheter, and when I first learned to crochet, I kept going so wrong all the time. And then I realised I'm really overcomplicating this. It's actually very straightforward. You just think it's harder than it is. And I feel with healthcare professionals and social care professionals, you have to reduce that sense of this thing is too big and just think, this is a person in front of me and I need to think about why they're not feeling brilliant. And that's what it is. And there was a paper by, I can't remember his name now, that I quote in the book about narrative humility amongst medics. And I really like that. It's just about listening carefully and being thoughtful. And so it's trying to avoid those shutters coming down, isn't it, that stop you, whatever is causing that, whether it is that you're overworked, overburdened, exhausted, stressed, whatever that is. Because somebody did say to me recently, oh, it's not all medics and it's not all this and it's not all that. And I thought, of course it's not. There's lots of good practice. But for some reason, the weight always goes against people learning disabilities. Why is it always this group who are receiving, at the end of the day, the worst healthcare? There's some reason why it's always that person and not other marginalised groups, which nobody should receive poor healthcare. But for some reason, people learning disabilities are at the bottom of the pile, and that needs addressing. So I think that's all.
Thanks for researching and writing that book. I do feel I'm naturally gravitating more and more towards people who are thoughtful in topics and subjects and have done deep work in it. And it seems like you have. Could you just let us know the name of the book, where to find it? And I'm such an audiophile. Is there an audio version of it? Because I would love to listen.
Oh, do you know? I don't know if there is. I'm sure there is. Yeah. The book is called Critical Health and Learning Disabilities, an exploration of erasure and social murder. And it's available, it's published by Routledge, which is a big, massive academic publisher. If you look at my blog, which is called My Daft Life, all one word, there is a voucher for a discount off the book, which makes it easier for people. And there is a lay version. I've written a version with pictures that's about 20 pages long. That is very readable with all the snappy main bits. So that's for people who don't want to read, which I completely understand, don't want to read an academic book. So there is an accessible version.
Yeah. Thank you again for doing this, and I appreciate you coming on the podcast.
Thank you. Yeah, I appreciate you doing this podcast.
As always, thank you for listening to Healthcare for Humans. If you've found any value in this podcast, I have 2 quick requests. 1, please leave a review in the podcast app that you're listening to my voice in right now. It really helps others discover the show. 2, share this episode with anyone who you think might benefit from it. For easy access to all our episodes and to support the podcast, visit www.healthcareforhumans.org. There you'll find our content clearly organized, topics, countries, themes, to help you choose what to listen to next. Until next time, this is Dr. Raj Sundar, reminding you that culturally responsive care leads to better patient outcomes. See you again soon.